Ladies and gentlemen, welcome to the OrthoFit podcast. Regardless of your fitness or education level, I'm so glad to have you join us today. Today, we're going to be talking about something that you didn't know you need to know about, which is the pelvic floor and considerations for keeping it healthy and having it perform well during exercise and in life. We're joined today by my friend and colleague, Dr. Julie Guthrie, a physical therapist with lots of experience in both orthopedics and pelvic health. Julie, welcome to the show.
Thank you. Thanks for having me.
Of course. Can you tell us a little bit more about just your background, what
Sure.
populations you treat, and your interests and things like that?
Yeah, sure. I've been a physical therapist for 24 years. I graduated from the University of Southern California, and at that time had an interest in orthopedics and was exposed to pelvic health in some of my clinical rotations, and found it to be the patients that were helped with our treatments were really inspiring, and I thought there's not a whole lot of education in the PT world for this. I should probably do more of it, and so yeah, I kept with that as well as my orthopedics, and so I've worked in different individual physical therapy practices. Started my own physical therapy practice about 13 years ago now, and so I enjoy kind of being my own boss and being able to help the populations that I serve.
Awesome. Well, I'm really looking forward to, I'm sure you have a lot of information that everybody needs to know about the pelvic floor. Probably some people watching this don't even know what pelvic floor really is. So we will get into that momentarily. I'm going to start off with some rapid fire questions, and this can be really difficult for professors and people with a lot of knowledge to summarize it very succinctly. So
Okay.
I'm going to ask you for a yes or no kind of one word answer, or if
Okay.
you really feel like you need to, you can give me a sentence.
Okay.
Okay.
Sounds good.
So can what I eat and drink affect my pelvic floor?
Yes.
Should I be peeing clear if I'm optimally hydrated?
No.
Interesting. Look forward to getting into that a little bit more. Is it normal to pee a little bit when you're exerting yourself, like when you're jumping or lifting heavy?
No.
Should everybody practice the Kegel exercise?
No.
All right.
No.
We'll be diving into that as well. If I go to pelvic floor physical therapy, do they need to touch me internally?
It's helpful on most people. So I'll do a qualified yes.
Okay.
But no, not always. We don't
Not always. Okay. We'll get more into that as well. Does pregnancy cause your abdominals to split apart?
Physiologically, yes.
And can anything be done during pregnancy to minimize the birth trauma later on?
Yes.
All right.
Maybe.
One word answers are hard, aren't they?
They are hard.
All right. So let's dive into some questions where you can give me more than one word answer.
Excellent. Much better.
So what does a pelvic health physical therapist do, and what conditions do they commonly treat?
Good question. So pelvic health physical therapists look at basically any region of the body that has to do with our reproductive, sexual, urologic, colorectal parts of our bodies. That can also include patients with that are prepartum or postpartum. So, or during the pregnancy, during their pregnancies. We can deal with kids that have urologic dysfunction, bedwetting, or constipation kind of issues. A lot of older individuals who have incontinence, things like that. Sexual dysfunctions, pain with intercourse, pain in the pubic bone region, tailbone pain, or other pelvic girdle, types of issues.
So quite a wide variety of different conditions that can affect different kinds of populations.
Yep.
Interesting. So let's get into some really interesting stuff. I'm going to dive right into what are some common myths and misconceptions about pelvic physical therapy?
Common myths.
Or you could say about your pelvic floor in general.
I think a lot of people assume that they have to strengthen their pelvic floor if they're leaking or if they have ever had incontinence. And That isn't always the case. Getting a full workup as to why is important. So we can talk.
Weakness is not the whole
Weakness is not
answer for
always the
everyone.
answer,
Yeah,
and doing Kegels are not always the answer for people. So
interesting.
we usually can look at just like someone saying, oh, I have knee pain, and somebody saying, oh, you should do a glute exercise. You might, and you likely, it is highly likely, but it's not in every case. So we need to take a
Gotcha.
peek at those kinds of things.
It's got to be personalized, just like anything
Correct.
else, I guess. Right?
Correct. And then I'd say the other misconception, I do have patients that come in that are very concerned about how much internal work we're going to do. There is a lot of education that we do. There's a lot of not touching that we can do that usually floors people, that it really surprises them on their anatomy and how their bodies work. That's always fascinating to me how many people do not know how their bodies work. So,
yeah. Especially
so
in that area, I'm
Correct.
thinking it's not something that we're comfortable just talking about socially with
Nobody
our
wants to talk
parents,
about
with
it.
our friends, right?
It's very
a little bit
frustrating. It's very
a
frustrating.
sensitive area for certain people
Yes.
and certain populations
Yep.
as well, which we'll get into in a little bit.
Yep.
So tell me a little bit more about, how does the pelvic floor normally function? Like, what is the role of the pelvic floor just with normal like breathing and movement and things like that
Right.
in
So
physiology?
so the pelvic floor has several functions. It's a support function for our organs. It obviously has a sphincteric function for our urinary system and helping kind of close off all of our tubes to prevent incontinence or leakage of gas and stool. It has sexual function, right? So it should be pleasurable as well as a functional part of our body. So that's where we can intervene, or where it's a little bit tricky, because a lot of other parts of the body, it's great if there's just no pain. And so in this region of the body, we kind of need it also to be pleasurable. So
Yeah.
it becomes a bit of an issue when things are finally not painful in the vaginal area or the rectal area or the anal area, but people still are not necessarily enjoying sex. So we have a lot of conversations about that too.
So on that note, maybe this is a good time to get into when should somebody see a sex therapist as opposed to a pelvic health therapist? Like, what kind of issues do you not treat and have to refer to somebody for sexual problems?
Got it. I would say we work hand in hand very frequently. We collaborate with sex therapists, or I make referrals out to sex therapists, especially if someone is talking about different strategies or asking questions about intimacy, how to connect with their partners. Maybe there's actual, there's a history of trauma where that goes beyond the purviews potentially of what we're working on, especially if the physiologic or physical side of things is improving nicely, and we're still seeing that there's a lack of connection or hesitancy or fears.
Yeah.
So those are definite times that we would refer out.
So they deal more with psychological and the emotional side, where I'm sure that plays a huge role in what you do, but you're going after more the mechanical and the physiology and the lifestyle changes and things like that.
Yep.
Awesome. Thank you. So in order to take good care of our pelvic floor and keep it strong and healthy, do we have to do specific exercises like Kegels or other specific pelvic floor training? Or if you're not having a problem where you're in physical therapy, just to strengthen it and have it be healthy, does general exercise strengthen your pelvic floor? Is this something most people need to be thinking about in their normal exercise habits?
Got it. If someone has a good exercise program and is not overloading the system with, I'll say heavy lifting with improper Valsalva, or like holding your breath and things like that. If someone is pretty active and has a good exercise program and does not have any symptoms, I would say the pelvic floor is probably doing a pretty good job. If there is a history of abdominal surgery, pregnancy, sports that load the body in a vertical manner, gymnastics, basketball, running, jumping, trampoline, those types of things, there's a lot of vertical load on the pelvic floor, or concentric and eccentric load on the pelvic floor. So there's there can be issues with that.
So if you just go to the gym and you're doing core strengthening and hip strengthening, squats and lunges and stuff like that, are you strengthening your pelvic floor as you're doing that?
There is correlative and overlap. Yes, so there you can get that. And I think the pendulum for a while in the pelvic health world swung pretty far on that side of just saying, okay, just breathe correctly and just do some leg exercises and you're going to be good. Maybe I've been around for too long, but I would say for a long time we said that you needed to do all Kegels, and then for a while we went to all exercise and no Kegels. I think we're finally settling back into a reasonable, logical process that looks at maybe we need both from time to time, and it depends on the sport, it depends on the symptoms, depends on someone's goals.
That tends to happen, right? There's like a new idea and then a massive overcorrection. And then over the next 10, 20 years, we gradually find the middle ground, right? Yep. The reasonable approach.
Yep.
Are there other body systems and body parts that are very related to pelvic floor function, either mechanically or physiologically?
I mean, our stress system, our neurologic system obviously needs to be functioning really well. Our urologic system has interplay. Our bladder needs to be able to stretch properly, and the sensation of that and how the messages are perceived in the brain really can have an interesting interplay with our pelvic floor.
So it's not always just a mechanical thing. Like it's very, very relevant how your brain is sensing what your pelvic floor is
100%.
telling you, what your brain's telling your pelvic floor to do, and just how your pelvic floor might react to other things going on in your brain.
100%. Yes. Our stress, our gut microbiome, our bladder sometimes become the boss of, of the body. And so patients present with symptoms of urinary frequency and knowing where every single bathroom is along their daily routine.
Mm-hmm.
And that's not always a great thing.
Yeah, I'm guessing that can be both psychological and physiological.
Correct. Yeah. So the bladder doesn't have an opportunity to stretch if you're going to the bathroom every 30 minutes. So the bladder muscle actually gets a little bit stiffer or more reactive. And so then every time that you get to that 30 minutes or 40 minutes, it's going to send messages to the brain and speak a little more loudly.
Yeah.
So, and then the other thing, I guess, to tie it back, you had asked about the function of things and we didn't talk about it. The diaphragm and the pelvic floor basically really are teammates. And I find myself explaining pelvic floor and diaphragm patterning a lot. So most of us don't breathe properly. A lot of us have lost the ability to properly breathe from our diaphragms. And so when the diaphragm expands and or contracts and drops, it moves all the abdominal contents downwards. The pelvic floor is underneath that. So if we think about it as a box, the pelvic floor is on the bottom and it must accept that change in pressure. And so the pelvic floor elongates. That's natural and it should happen. As we exhale, the diaphragm comes back up and the pelvic floor follows that. So for coughing, laughing, sneezing, lifting, carrying, our daily function, the pelvic floor should be able to elongate and then shorten back up again. And so proper diaphragmatic breathing helps to maintain the proper length and the proper nutrition, basically blood flow and oxygen to the pelvic floor. By not breathing properly, the pelvic floor kind of gets trained in a shortened position. And then usually we're smashing it while we're sitting all day long, and that's not good either. So then we don't get blood flow and oxygen with that. Then you add in stress, where a lot of people hold their stress in different areas. So we have people that come in with, jaw pain, neck pain. Other people will clench their abdominals. Other people clench at their pelvic floor. And so it's pretty interesting when we go through this discussion with patients, and I ask them to go home, and anytime that they are in a stressful situation, kind of take in where they feel that tension. And it's pretty interesting when people come back in and they go, I feel that in my rectum, or I feel that in my scrotum. And so my young guys are a really interesting population. And there's a lot of them that present with scrotal pain, tip of the penis pain, pelvic pain that is related, I'll say it's related to stress, or it seems like there is a stressful trigger with that, along with the other physiologic and biomechanical kind of loads.
So there's just so much involved. It sounds like there's the physiology of your reproductive system and your digestive system and your breathing, but then there's your psychology and your emotions and your nervous system and how it's related to stress. So I can see how this could be overwhelming for someone who doesn't know a lot, and then maybe it's a sensitive area that they don't want to talk about, and it's not one cause, like this is the cause of all the problems. So
right, and people go to their doctor.
Need to go and see someone like you to help, get through the weeds and like, what are the things that are causing my problems, because there can be so many different things to consider.
Yes, and the patients go to their doctor, and a lot of people just want to get a simple answer, one pill, go home, do one thing, and really it's multifactorial, and so we spend a lot of time, as I said, we spend a lot of time talking. It's a lot of education. There's homework, but it's sometimes physical homework, and sometimes it's overall looking at patterning and behaviors and thoughts and things like that. So
yeah, treating the whole person, not just treating the organ itself in isolation. Is this only relevant to people who are having reproductive problems, pelvic floor pain and things like that, sphincter function problems, or is pelvic floor often relevant for people with other issues, even if their pelvic floor is not where the symptoms are? For example, is this something that you should consider if you have back pain or hip pain or any other body parts related to pelvic floor?
Yeah, so we should put in a link after this to I tend to use, there's a great questionnaire by a lovely colleague of mine who runs her practice down in Orange County. And it's a wonderfully validated questionnaire called the Cozine questionnaire. And I've educated all sorts of orthopedic and general med physicians on utilizing this questionnaire, because it does ask about back pain. It does ask about tailbone pain. Have you ever had a fall on your tailbone? Do you have digestive issues? Like all of those encompassing types of issues can also be related to the pelvic floor. So by using this questionnaire, if you say yes to, I believe it's three or more of the questions, it's greater than 75%.
Very likely that your pelvic floor is a contributing factor for you. Wow, that's fascinating. We'll definitely link that in the show notes so people can take a look and see if that's something they need to consider. So if somebody is say someone is going to just a regular physical therapist who's not a pelvic floor specialist and they're getting their back pain treated, is there anything other than that questionnaire that might tell them that they should maybe get their pelvic floor examined or see someone more specialized in it?
Sure.
Say it's for back or hip pain, not for pelvic floor pain.
Good question on hip. Oh yes, hip's the other big one. Yeah, labral repairs, very hot, very. I see a lot of labral.
Common injury.
Well, the connection with, or the correlation with having pelvic pain with labral repairs actually is not trivial. So I've seen quite a few.
And yet you see labral repairs being treated in any physical therapy, being treated by new grads, being treated by people who don't know more than what you learn in school about the pelvic floor. So it sounds like, maybe tell me if you think this is a fair advice to give people, but if they are having chronic hip or low back pain, maybe if they don't get better with other physical therapy, then seeing somebody who also knows about the pelvic floor might be a good strategy. People who know about pelvic floor tend to know about the low back, but not the reverse is not always true in a specialty level of education.
Sure. That I would say that's a good recommendation. The other thing is that if you have a history of any level of incontinence, if you've had a pregnancy, delivery, if you've had abdominal surgery, absolutely there could be a correlation.
Recently or ever?
Ever.
Okay. So let's talk about one of the big things that we do know that pelvic floor physical therapy treats, which is incontinence. I know there's a lot of people who probably, maybe they're runners or they do a jumping sport or a heavy weightlifting, and they're like, yeah, when I go all out, there's some leakage, but I can still run and then I'm fine after. So is it ever normal to have leakage?
It's never normal. Just because it's common does not mean that it's normal. But I'm going to say, if people are not bothered by it, then I mean, they're not going to be coming in seeking physical therapy, right? So if someone is coming in, they're usually bothered enough by it. So at that point, we need to be looking at whether the pelvic floor is incoordinated, right? So or discoordinated. Do we have discoordination? Do we have weakness? Do we have just an overload with everything else not working quite properly, right? So do we have an old hip injury, an old low back injury where one side of the glutes are not firing quite as well as the other side? And so when someone drives off of the wall, pushes off the wall, and I mean, like I say in swimming, but if they're pushing, leg press, single leg, or they're going to sprint and they're pushing up a one leg versus the other, maybe that one leg is just a little less stable, and just that little bit creates a pelvic rotation or a load on the pelvic floor that just is just not enough.
Just too much.
Yeah. So I usually equate it to an arm wrestling match, right? So if pelvic floor is here and your abdominals are here and you say 1, 2, 3, go, whichever side gets the jump is probably going to win, right? So if the pelvic floor has not basically changed or is not engaging in some capacity to meet that load, you potentially have problems.
So it has to match the demands of whatever you need
Correct.
to do with your core and with your body. So maybe an athlete needs to have a much stronger pelvic floor than just what you need.
Correct.
Day
And
to
so
day.
with our weightlifters or power lifters and whatnot, it's not just about concentrically actively contracting the pelvic floor. It's figuring out a graded way of building tolerance to whatever that increased load is, and to their Valsalva, to their progressive, to their progressive breathing pattern with it. And so sometimes it needs to go a little bit more slowly on their progressions. Maybe it's their belt, maybe there's an issue with their belt usage, but frequently there's a mismatch with it.
So let's talk a little bit about training for the pelvic floor, if for incontinence and in general, because you said earlier that not everybody should do Kegels, but that it's probably a good idea for many people to do. But then we're also talking about the pelvic floor doesn't just function concentrically. It doesn't just squeeze. You have people who have problems because they squeeze it too much because that's their stress reaction.
Yep.
So I'm sensing the pelvic floor needs to balance between stretching and contracting and be balanced with your other breathing and core muscles. So tell me a little bit more about who should do Kegels and how do you know how to train someone's pelvic floor if they need more strength, if they need more relaxation, more lengthening, etc.
Right. So if someone has had a history of pelvic pain in any capacity, so that's pain with inserting tampons, pain with gynecological exams, pain with intercourse, pain with bowel movements, that sometimes will give us an indication that the pelvic floor it's impaired in its ability to elongate or relax. So we've got to figure out that first. So if somebody is presenting or has that kind of history, I usually say, hey, we need to figure that out first before we assign you Kegels. Because a lot of people will just go online and say, if I'm leaking, what do I do? And Kegels come up first. So, and that could potentially create more issues, right? So the muscle is over contracting. So, it's like walking around with our shoulders up here. They can only go so high before we start having, more neck issues or more shoulder issues or something like that. So that's the first thing, is that I would say those people, we need to proceed with caution. And then, the first thing we really want to look at is the diaphragmatic breathing. So I always go there first and say, okay, quality of diaphragmatic breathing. Can we get 360? Can we get the ribs to expand forwards, laterally, posteriorly, and get that nice expansion? If we get that, then we look at touching either externally on the sit bones, just to the inside of the sit bones, just to the inside of the tailbone, and basically feeling ever so slightly by the end of an inhalation, does the pelvic floor come into your fingers just a little bit? And then it should go away on the exhalation. So it should be just this nice, small little bit of movement. I mean, a couple of millimeters. Some people push really hard and they can't feel it.
Not something you're seeing from a camera, something that's subtle and you're just feeling a little bit
just
of pressure.
Yep, but people can touch on themselves. So I'll have people lie down on their sides, maybe lie in happy baby pose, and can they feel themselves by the end of their inhalation breathe into their underwear? You should feel just a little bit more touching of the scrotum or the perineum touching your underwear. So that's the first thing. If you can feel that, then we know that the pelvic floor can elongate a little bit and come back to normal. At that point, then we'll do contractions, usually of a concentric nature first, of inhale, relax, exhale, and can you contract? And can you lift up and away from your underwear without squeezing your butt, right? So we're not riding a horse, we're not squeezing a dollar bill between our cheeks. We're just trying to lift up and away from our underwear. We see how long someone can contract and hold that way, and we're trying to train them into a decent amount of those contractions. Once those look good, we also look at, just like any other muscle in the body, having having our endurance muscle fibers and our fast muscle fibers. We need them also to react quickly. So we also ask for contract, relax, all the way on, all the way off, all the way on, all the way off. So if someone can do that, we have long contractions and short contractions. Then we go into more of that eccentric control. So you're in the gym, you're hitting weights, you got your concentric and your eccentric. We don't just drop the weights normally, right? So it's the same thing in the pelvic floor. If, usually my correlation is that if you wake up in the middle of the night and you're thirsty and you go to the refrigerator and you go to grab the gallon of milk because you're thirsty, the second that your hand touches that, it knows whether it's full or whether there's 2 drops, right? So same thing in the pelvic floor. You're not going to always contract 100% or nothing. So we work on some different graded contractions to teach your brain to understand how to elongate or how to soften that contraction and contract partway.
So let me see if I understand, and you can tell me if this is accurate or if there's anything you would change or add to this. Okay. So in layman's terms, when you're breathing with your diaphragm, the air pressure is supposed to go down into your abdomen. Right.
The diaphragm changes pressure. So they're 2 different systems, right? So you got our rib cage and you got your abdominal cavity. So it just basically pushes down onto the abdominal cavity, and that pressure system then changes, right? So that pressure system moves. Gotcha. It's not that we're breathing our air. Our air doesn't go down into our
right. It just
belly.
goes to your lungs, right?
Exactly.
Okay. But as you inhale, there's more pressure.
Correct.
And that pressure shouldn't stay up in your upper chest.
Correct.
It should go down into your abdomen.
Correct.
And when that happens, the pelvic floor is supposed to lengthen, but that doesn't necessarily mean it's relaxed. It can be working while it's lengthening.
Correct.
And so just like any other muscle in our body, we want to train in different positions, different demands, different speeds and intensities. Not everything is 100% or 0. They have to use it in the middle. So in pelvic floor training, it sounds like that's no different. Sometimes you need power, sometimes you need endurance, sometimes you're doing something gentle and doesn't have to work as hard as possible in order to do the gentle activity. Right?
Perfect.
Awesome. Other than pelvic floor muscle training, are there other strategies that you use to help people with incontinence?
It kind of depends on what kind of incontinence, how they're presenting, right? So we can have urge incontinence or urinary urgency, where people are going to the bathroom very frequently or rushing, which is an issue, especially for patients who maybe have a history of falls, right? So, or have some sort of balance dysfunction. So, we don't want people rushing to the bathroom. So there are postponing techniques, relaxation techniques to try to get someone to store a little bit longer and get themselves to the bathroom safely. So we'll work on those. We definitely talk about fluid and hydration, because I think that, that is another myth, that by stopping drinking,
like
you pee
before
less.
bed or
no, just
general?
peeing. Like that if I don't drink, that I'm not going to go to the bathroom. And the problem with that is that by not drinking, your bladder becomes quite acidic. The urine becomes very acidic,
because it's not as diluted with water.
It's not as diluted with water. So therefore, that is one of the biggest bladder irritants. So,
and a bladder irritant makes you have more urge to pee.
Correct. Right. So even though this is usually our people who are already peeing very frequently, they don't want to, so they don't drink. And so I usually coach people through maybe just different goal setting, right? So they may be that they have one of those like a little glass of water, and that by noon, we just need another 4 ounces. We need another 8 ounces, something like that. It's not about carrying around the huge gallon jugs and trying to, complete that, by the end of the day.
Yeah.
Overhydration is just as much of a problem. And by overloading the bladder, you're going to end up urinating more frequently.
And that's why you don't want to always pee clear. Is that right?
Correct.
Can you tell me more about that?
So yeah, I mean, that can lead to hyponatremia, and we obviously do not want the bladder to be in this overloaded state constantly either. The caveat with that, though, is that if we have somebody who's really active, who's going into an athletic event, or that we're going into a region of the country, that is quite dry, or if we're at altitude, we're going to need to change that fluid, that fluid intake. So I would say that, that's very individualized, but as a general rule, we want people to be urinating basically every 2.5 to 3 hours, and usually not overnight. For some people, a small percentage, getting up once a night is normal, but if you're getting up to pee on a consistent basis overnight, it's not normal. It's common, but not normal.
And that's something that I hear just in my populations, people who are having trouble sleeping and they wake up in the middle of the night and it's like, well, why? Oh, well, I always have to pee 2 or 3 times throughout the night. And I'm like,
not normal.
Is that normal? Does that person do I need to send them to Julie?
Yes. And again, it doesn't have to be that they come for 14 visits or something like that. I'll be honest with you, early on in my career, I worked on trying to trick or work on people's patterning overnight.
Gotcha.
And there are 3 things that people need to do in life. That's eat, sleep, and poop. And if we don't do those 3 things, life is not good. So if you postpone at night and you just can't go back to sleep, you've lost even more sleep than just getting up and going to the bathroom and going back to sleep frequently.
Can't fall back asleep.
Can't fall back to sleep. So what I've found is that by working on storage during the day, I've only had 1 patient where it did not work over the last 20 years. That by working on patterning during the day, you teach the bladder to store better. It works every time. That the overnight, it carries over overnight.
Wow. So you can actually train your ability to hold higher bladder loads, kind of like a muscle or anything that you get used to over time. Your bladder can adapt.
Absolutely. And the best example of that is our patients with that are pregnant, right? So we have the baby taking up space and squashing the bladder for a really long time. The bladder doesn't get to expand. And then after, it should be able to expand again, but people tend to have increased urinary frequency, and that's normal during the 4th trimester, after delivery. That's actually normal for a while to have still increased frequency because the bladder's not used to it. It has to get used to stretching again and used to storing more urine.
That makes sense. Interesting. So on the subject of urination problems, and I've seen a lot of people seemingly having to go to the bathroom all the time, maybe it's just since COVID, because they're working from home and the bathroom is always theirs and they can take breaks when they need. So they never have a reason to hold it for a long time. Then they go back out in the world and they can only go an hour and they have to use the bathroom. Or if you're going for an hour meeting or car ride, you get nervous. Well, if I have to pee and stuff like that. So talking to people about pee issues, I talk to a lot of older men and they say, oh, you'll see when you're my age. That's just what happens when you get older. Your prostate grows and then you just have to pee all the time. And then I hear different things about pumping out the urine, pushing out the urine, having to pee just so many times throughout the day and not ever completely feeling like your bladder is, now it's empty. Right. So tell me a little bit about what are urinary problems that men face, especially with aging, and what are some things that they might be doing they should try to avoid, and what are some strategies to help with that?
So a couple things. I mean, yes, as men age, prostate can enlarge. It does create issues in terms of complete urination. So if we think about the bladder not fully emptying because of where the prostate is and it not allowing all the urine to come out, that bladder then fills again back up to a sensation of needing to pee more quickly, relatively. And so that can happen. And a lot of guys are not used to feeling that. So I think their alarm system goes off a little bit more quickly with that. The other thing is that a lot of guys stand to pee. And so when we stand up, we use a lot of muscles to actually stand, right? So we have all of our leg muscles and our abdominal muscles, or just our core is in a different position, right? So our pelvic floor doesn't have as much of an ability to relax. So a lot of my guys, I have them sit down. They can usually pee a little bit easier.
Oh, interesting.
So, yeah.
So,
and they're breathing. So then if they're breathing and you feel like you're not emptying, a lot of people will hold their breath and strain. My fast peers or people that just need to go to the bathroom quickly and or stressed, and so they'll push their urine out. We don't want that either. So again, any of our breathing techniques to let the pelvic floor muscles elongate or to relax, we try to use those instead. At the very end of urination, quick contraction of the pelvic floor, anything. So with the penis, basically where the pelvic floor is, urine is not going back up above the pelvic floor. So by contracting the pelvic floor, you can clear the line and just get that little bit of urine out. That's fine. But that's at the very end of urination, not throughout.
Yeah. And is it okay to pump multiple times at the end? Or and when we say pumping, we mean contracting your pelvic floor muscles, right? Is that you should do it multiple times or just once?
Yeah, 2 or 3 times is fine.
2 or 3 times is fine?
Yeah.
Okay. So we've talked a little bit about proper breathing techniques and not straining to use the bathroom. And we talked about urination, but we should talk about bowel movements a little bit as well. So when we say proper breathing techniques and things like that, like what does that actually look like, or what are the breathing techniques, and are they the same or different for urination and bowel movements?
Good question. So I would say the inhalation is somewhat similar. I tend to draw people's attention to what they're feeling around their tailbone and their rectum at the time, just because that's where obviously the goal is at that point. The urge to hold your breath and strain happens immediately with stool consistency. So if stool consistency is hard, or harder, or you have a history of constipation, straining is the first instinct to try to move that stool. And so relearning how to not do that tends to be through a sh or a s kind of action where you can develop abdominal pressure without holding your breath. So Valsalva, or holding your breath basically is going to increase your blood pressure. Not good for bowel movements. It strains the pelvic floor. Really not good, and sometimes not overly effective to actually get the stool out. So we're working on trying to breathe first to allow the stool to drop down, and then applying some abdominal pressure if needed to be able to evacuate. Alongside,
if your stool is soft, maybe that's not needed though.
Then it's not needed. It may not be needed at all, especially if we're utilizing, like we have reflexes that help us to go, right? So first thing in the morning, after being asleep, is a common time. After you're drinking hot liquids, after a meal, those types of things will increase our motility, and that's a good time to try to go or to honor our body. If you ignore that, the body goes, oh, okay, cool, I'll just store longer.
Yeah, we're not going to be able to go. We're not going to be able to go for a while. Just go into maximum storage mode. We're on a road trip.
Exactly. So that's a problem, because the body then starts to ignore those signals. So we first try to get people back onto a bowel program or bowel patterning kind of program, and then also teach people bowel massage. So after you eat, about half an hour after you eat, there are massage techniques on the abdomen around the colon to be able to kind of help move things along, and then hopefully the next thing is that there's an urge to actually go to the bathroom.
Is this massage technique something that you can teach our viewers right now?
Right now, I don't have a model to do so, but yeah. So basically,
just talk us through it.
Yeah, we can talk. Yeah. So basically, the colon, we have our ascending, transverse, and descending to sigmoid colon, and so basically, we can do it one of 2 ways. In the Eastern medicine world, people who go and get massages will say, oh yeah, they finish with this nice massage on my belly. And it's like, yeah, that's kind of working on our small intestines and our large intestines. So So there's two different techniques, but a lot of videos will show just kind of gentle strokings this way. I tend to get a little bit rude. I say that we're physical therapists, we got to get in there. So usually we'll work on the descending colon and try to kind of help to move stool down. But it's generally circular kind of motions going from the left ribs down to the inside of the left hip bone, and then spending about 2 or 3 minutes there. Then we'll come up and work on the transverse colon. So same kind of thing, going from the right rib cage underneath all the way across to the underneath the left rib cage over this left side. So basically we form an I with the massage, then we form an L with the massage, and then a U with the massage.
Awesome.
So, after you eat, 20-30 minutes later, it's taking maybe 6 to 10 minutes to work on that massage. Usually not, and I usually tell people breakfast after being overnight, and breakfast and hot liquids with coffee or tea in the morning.
Not usually.
Maybe not the time to do it, but lunch or dinner for sure.
Awesome. Thank you so much for teaching us that. It's good to have something useful that we can apply right away.
Yep. I thought it was a joke until, graduating from teaching school, I was like, this doesn't work. And then had a dinner where I said, oh, yeah, things aren't moving very well. And had someone listening to the gurgling. And so if you feel gurgling, if you hear gurgling or feel gas movement and things like that, feel like you need to pass gas.
Gotta get things
That's
moving.
all good. That's what it's supposed to do.
So it's kind of like traffic, right? The cars in front need to get out first, and then the ones in back get to go.
Yes, exactly.
Awesome. Okay. So now we talked about mechanical aspects of bowel movements. Tell me more about how our diet and food choices affect how our bowel movements will go, and the differences there.
So I end up talking a lot about this, very passionate about stool consistency and overall our dietary health in this country. Not that this is a podcast only for this country, but I'll talk it. The standard American diet stands for SAD.
Lots of countries follow the standard American diet.
Standard American diet does not help us. So in general, we want to see people consuming at least 30 to 40 grams of fiber in general, for most people. Having, that's for, females and males, females 30 to 35, males 35 to 40. Most people don't get half that. Standard American diet is generally half of that. So that is one portion, one thing to consider. If you're going to, add in fiber supplements, or you're going to try to make changes in the diet, consuming enough fluid, enough water, so that fiber can actually work its way through, really important too. So some people say, hey, I'm going to go on this great diet, and they don't drink any extra water. That can cause problems as well. So we don't want that. So enough fluid intake to match that fiber. And then if we really look at some of the best gut microbiome studies out, and we look longitudinally at things, cultures and people who consume 30 different fruits, seeds, nuts, vegetables, grains, any plants, that kind of thing in a week, generally have healthier gut microbiomes than those of us who eat from Costco the same packaged food every single day.
Not a lot of variety.
Correct. Yeah.
So the more different kinds of foods that you're eating, the more different kinds of bacteria in your gut that you're feeding. Correct. And so you have more biodiversity basically in there.
Correct. You're going to hopefully have a good match between good bacteria and bad bacteria. So that will gives me a little in to say, if you have a history of SIBO, if you have a history of some sort of leaky gut syndrome, we always want GI, colorectal nutrition support, so that we're collaborating to, kind of be able to make some of these recommendations. So, but in a generally relatively healthy population, we can make those recommendations. But if we have dysfunction or latent dysfunction, history of dysfunction, I'm usually getting some assistance with that.
Yeah. It's tough. Not everybody knows that they have leaky gut or SIBO. Probably a lot of people listening to this don't even really know what we're talking about. But to simplify it, it's just not a good balance between healthy and not so healthy bacteria in your colon, basically, or in your whole digestive system.
Right. And symptoms usually are bloating, gassiness, fluctuations in stool consistency, things like that, which I think it's important to note that a lot of people think, or it's a myth, that you have to poop once a day and that's normal. It can be 3 bowel movements a week can be normal for someone if that's always been that way. 3 times a day can be normal for someone if that's been like that. What we're looking for are changes in patterning, or something that's happened that has led to that change.
So I think fiber is pretty interesting because whether your stool is too loose or you're constipated, it kind of helps you meet in the middle. So if you are constipated or if your stool is too loose, how does that affect the sphincter function of the anus, and how does that affect the health of your pelvic floor?
So when we're trying to hold back mass,
Mhm.
right? I mean, urine, having a liquid is a little bit of a different story. But when we're trying to hold back mass, if that mass is all of a sudden kind of watery and loose, the contraction that you have to do, the amount of squeezing that you have to do is a lot harder, right? So anybody who's had the flu, anybody who's had Montezuma's revenge, you're running to the bathroom a lot faster, right? Because you just can't squeeze that hard. It's really difficult. So fecal frequency, fecal incontinence, those types of issues can happen at that point. So, and on the reverse, if we have chronic constipation and passing really, really, really large stools, we can get basically elongation of that tissue, and that tissue compared to the bladder doesn't necessarily contract. The rectum's a storage area. So if it just learns and it gets really stretched out, we can get basically a mega colon where the stool just says we can hang out here.
It just hangs out there for way too long. Doesn't come out when it needs to.
Correct.
And I would think that if the stool is hard and you're trying to push it out, that might also lead to more straining and too much pressure and maybe hemorrhoids. Is that accurate?
It can lead to hemorrhoids. It can also lead to prolapses and things like that. So basically, there's not a whole lot of bony attachments for any of these muscles to support, right? And there's just connective tissue in between these tubes. And so if that connective tissue all of a sudden gets a little bit wishy-washy, we can't really get it back. It's really difficult. So the rectum or the colon can basically kind of curve towards towards the vagina, and we can get pocketing. And those rectoceles, basically people will go to the bathroom, they'll defecate, and then 20 minutes later, they stand up and they move around. They go, oh, nope, I've got more. And it's because the pocketing within that little, it's a little pocket basically. And the stool that was there then moves down and stimulates down onto.
It doesn't come out when you want it to the first time. And just once everything's empty, then eventually it comes down. Otherwise, it's probably growing bacteria in there because it's in there for too long and stuff. And then as far as like diarrhea would go, if that is something that everybody gets that once in a while and you eat the wrong thing or just an off day, but if that is a habit for your body, then how does that affect the function, like the sphincter function of the pelvic floor?
Well, again, you're going to probably be contracting the pelvic floor a lot more at that point. So you may have a habit of gripping. You may be going to the bathroom, more frequently. So bladder might be emptying as well at that point. So we may have a storage issue within the bladder as well.
Can that make it so that you can't dilate the opening enough, and so then you have to strain more to push against like a narrower opening?
That's an interesting question.
It's a theory I've wondered about.
Yeah, I mean, I think chronically, if you really truly do not have an opportunity to have typical bowel movements or normal stool consistency, I could see that. The other patient population that sometimes has issues with this are patients who have had colon cancer or colorectal cancer and radiation within the area, or surgeries, fissures, and hemorrhoid repairs and things like that, or hemorrhoid removals. You have a little bit of scarring or a little bit of change in the tissue there. It doesn't want to stretch as much.
And while we're on this lovely topic, what is your opinion on the squatty potty? That's something probably everyone's heard of. What's proper posture like for a bowel movement?
So we do want knees to be, it's ideal to have the knees higher than the hips. So the invention of the modern toilet created all sorts of issues. And then the invention or the raising of toilets for orthopedic issues has also created issues, because then the hips are even higher than the knees. So I have a lot of patients who will use squatty potties or a step stool. I have patients who will squat on the toilet as well, just to get the knees really high up. But those are all, they're good strategies to get the alignment of the rectum and the anus in a better position. So there's less resistance. It doesn't have to take a left
so
at
then you don't have
Albuquerque.
to strain because there's less
Ideally,
resistance.
correct.
Yeah, or strain not as
It's much
much.
easier.
Yeah. All right, let's switch gears a little bit.
Okay.
So talk to me a little bit about pregnancy. How does pregnancy affect pelvic floor function, and what are some needs for pregnant or postpartum women that can be serviced by pelvic physical therapy?
Got it. This population, I feel like, we've done as a profession, we're improving greatly on our service to this population. Whether you have a C-section, whether you have a vaginal birth, you still had to carry the kid for 9 months. And that growing weight and strain on the pelvic floor is there. So I think it's a bit of a misconception to say, oh, I had a C-section, I'm not going to have any pelvic floor dysfunction. You've had major abdominal surgery at that point. The chance of pelvic floor dysfunction or abdominal pelvic dysfunction is pretty high. Additionally, during the pregnancy, frequently, in the beginning, we talked a little bit about, do the abdominal muscles separate? It is normal to have a little bit of separation of the abdominal wall. The question is, in a lot of cases, it will also shorten back up a little bit and kind of come back and close together. There was a period of time, the pendulum swung, that we talked a lot about. We focused on exercises to close that gap if it persists postpartum. That has shifted again to, can we make it functionally no matter what length it's at? We can't change the connective tissue necessarily. So can we make it function better? And we know definitely that we can with particular, strategies, exercises, breathing techniques, postures, and things like that, looking orthopedically. So it is a blend of orthopedics and pelvic floor at that point. Now, having said that, if you've had a vaginal birth, the chances of having some level of pelvic floor muscle damage neurologically as well, like the nerves have been stretched, the muscles have been stretched in the area. We know this. So getting them to work again, super important. Not on day 2, but, by weeks, 2, 4, and 6. I mean, there's a lot that we can do. So we always encourage people to stay home, get rested, get all the support you need for that, first week or 2. But,
Is this something that normally the body heals itself and only once in a while something goes wrong and people need physical therapy? Or is this something that very commonly people have something to gain from physical therapy, even if they feel like they can kind of manage okay? Like, how prevalent are these postpartum pelvic floor related issues versus the body just healing itself?
Very, very common. Not everyone, but they're very common. And again, just because it's common doesn't make it normal. So I think we tell moms, we do a huge disservice in our population to say, get up, get to work, go back to work. And, oh, I had that pelvic girdle pain. I had tailbone pain. I had incontinence. You're lucky it was only this. I mean, I get patients that come in with horrible stories, and it's heartbreaking to hear the lack of consideration on that. So yes, I mean, I always tell people, even if it's just for a visit or 2, regain some confidence, get some really good instruction on what you can do to deal with your particular issues, not just globally.
Yeah. So not everybody who goes to physical therapy has to be a year-long member to learn and get something out of it. You can probably
and moms are busy. Moms
a
are
lot of good
overwhelmed.
education the first couple days, right?
Yep.
Only for people who are really struggling to improve or need a little bit more extra attention do they maybe come back a little bit more often. But even just going for one visit, you could probably learn enough to make a difference.
Yeah. And I would say it all depends on how much tissue damage, what happened during the delivery. Our patients with perineal tears afterwards, they benefit greatly because they're healing. And once their tissue has healed, frequently sex is uncomfortable because they have a wound that has a stiffer scar tissue. So, we teach scar mobilization. We can, help with that. And, really, I mean, again, a couple visits, usually they're good. And then they're much happier and their partners are happier. So that's good.
Amazing.
Yes.
There's a few different patient populations that people might be wondering how they fare with pelvic physical therapy. Okay. So we're thinking about transgender people and gender reassignment surgeries is something that people are more aware of and talking about more
in the pelvic health world. We're talking about it a lot, and we get a good amount of training in. There are regions of the country where it's more prevalent and we have more greater opportunity to be able to serve that population, and others that are not. There's a lot that we can do pre-surgery or throughout the preparation phase. There's obviously a lot post as well in terms of dilation and teaching breathing techniques and all sorts of management with their new anatomy.
Awesome. How does a pelvic physical therapist navigate things if they are working with a patient with strong religious beliefs about modesty or exposing your body and things like that?
I had quite a bit of experience with that. It ends up being more of a coaching session. Obviously, whatever a patient comes in with, their consent and their requirements for engaging with physical therapy.
You don't have to do anything you don't want to do, right?
Absolutely. And so I've had quite a few patients where they are fully dressed. I don't get to touch them. And basically it becomes a good challenge on my side of things of saying, okay, what do you feel? How can I find better language to reach this patient and coach them through what they're feeling? Then I just have to accept that there's limitations on what I can confirm objectively. It is a lot more of a subjective report at that point, but it still can very much work.
Awesome. And how about patients who are sexual assault survivors? What are some considerations for working with them, or how do you get them to be more comfortable in a physical therapy session?
Great question. I would say that population, again, we are improving over the last decade. Trauma-informed care is now very common practice to be able to have greater skills to be able to serve this population. Again, consent is huge, and I have patients that we take months and months and months to maybe get to be down to underwear or working internally. Sometimes it's me coaching through them touching themselves. Sometimes it's me having their partner come in, or somebody trusted that they're willing to allow them to touch, and that works sometimes. And sometimes we're working with, again, either sex therapists, psychiatry, psychology, to be able to support those patients as well.
Thank you. It's good to hear that you have strategies, because these are some of our most vulnerable populations who maybe don't always get the advocacy and care that they need.
Yeah, and I would say that the consent, when I mention consent, it is consent every minute, because just because someone feels that they're in a physician's office or they're in a PT office and
they sign a form on the first day.
Yep, and okay, it's fine. Yes, go and do it. The second that I see someone dissociating, the second that I see someone not pausing and checking out of what we're doing, no matter whether we're working externally or internally, we have to stop and check in and make sure that consent is still there, because and I've seen this mistake. I saw this mistake this past week, and I say mistake being that patient thought, I thought I was ready with this other therapist, and I really wasn't, and we've had to do a little bit of cleanup work from that. So a lot more talking, a lot more working through kind of what that may look like in the future then for us working together, and and it's fine. Wherever anyone comes in is totally fine. It does sometimes change the treatment plan of how we're progressing things.
Thank you. So at this point, I want to open it up to you. Is there anything that you just want to share with people, things that you think that more people need to know about, or something you want our audience to hear?
I would say that at any age, if you have questions about your body, we're living now in a world where you can Google a lot of things. But I would say in the Instagram world that the answers aren't so simple. And so, finding someone, there are a lot of people who now specialize in pelvic health. You can find someone that understands, and you can find someone that will hear you and listen to you and answer your questions in a professional manner and in a sensitive way.
Awesome. Thank you. Quick follow-up question on that. If somebody is going to see a pelvic therapist who's not you, are there any green flags that tells them that they found someone really good, or red flags that says, oh, maybe
Ooh.
this isn't the best person I should see. Maybe I need to find a better fit.
Yes, I mean to
Or
throw people under the bus. Okay,
no,
cool.
no specific people. I just
Yeah.
want, if somebody who's listening to this, if they're going to go for the first time in their life to see a pelvic therapist, what are some signs that they're in good hands, or some signs that they should be having second thoughts?
I mean, you need to feel safe. You need to feel heard, and not rushed. I would want a thorough question and answer time about all the systems we've talked about, right? In terms of history, both emotional, physically, physically and emotionally. I would want someone asking questions about all that. Red flags. I mean, not being in a private room might be a red flag, right? Not seeing, not feeling like, things have been cleaned really well. That might be another issue.
Not talking about consent multiple times.
Right. Yeah. I'll be clear too. There are certain organizations that are requiring people to sign waivers or sign consent every single time. A lot of us do not do that. We get verbal consent, from session to session, and that's okay. So I wouldn't call that necessarily a red flag, but a lot of large organizations will require that, or require that you approve or disapprove of someone to be in the room.
Like chaperone. Yeah. Gotcha.
So.
So where can people get in touch with you? Like, can they look up your clinic, or you have any other information that's out there?
Yeah, I mean, my clinic is Synergy Physical Therapy, so with an IE, French spelling. So Synergy Physical Therapy in North Redondo Beach, where I have a small studio. I love it there. It's great. Love practicing in the South Bay now, and love Los Angeles. So I'm here, happy to answer questions. But if they're not here, the American Physical Therapy Association has a great Find a PT, kind of indicator. The Herman Wallace Institute has a Find a PT, indicator, and you can usually find someone, ideally somewhat close, to at least start the conversation. But I'm always all ears to listen to people.
Awesome. I think this is going to be really eye-opening and really helpful for a lot of people. Thank you so much for your time and your input and experience and everything. It's been great to have you on, and hopefully we'll have you back at some point.
My pleasure. Thanks for having me.
Thank you.